Thanks, Michael. I hope the clock hasn't started. Okay, so I know that I'm the last speaker and we're all looking forward to morning tea. In Australia, we've seen a shift downwards in consumption, but that's not to say we still don't have problems, both illicit and illicit drugs. We've got people regularly exceeding our national guidelines, both in terms of lifetime risk and single occasion. We continue to misuse legal medications in a way in which they weren't intended. And of course, tobacco consumption has declined, but we still have 1 in 8 that are daily smokers. It's a significant cause of death and disability, whether it's accidents or whether it's dependence or consequences of use. So it remains a public health challenge, but really the big public health challenge, and this is data from SAMHSA, is that the majority of people who should think about doing something actually don't feel they need treatment at all. And of those who do, the majority of those don't actually take the effort to engage in it. So if we're sitting waiting for people to come and see us, either in primary healthcare settings or in specialist treatment settings, then we're going to wait a long time before they come through our doors. So the question is, why would we bother thinking about screening, brief intervention or referral to treatment in an emergency care setting? Well, firstly, if you're going fishing, it's good to go to places where the fish are biting, and they certainly are. Overrepresented in presentations, we see that alcohol-related presentations in particular are a cause of concern. About 1 in 10 of all attendances, estimated by the College of Emergency Medicine. Overrepresented in injury presentations, overrepresented in intoxicated trauma patients. But it doesn't stop there. Of course, we're also seeing recently in Australia an emergence of methamphetamine-related psychosis. 2/3 of those had been through an emergency department before their first presentation with psychosis. So they'd actually been in the environment where they were going to end up to be treated, but hadn't necessarily been recognised. I guess more importantly, from my perspective, however, the timing is right. There's often a presentation in a time of crisis, and that renders an opportunity to be more willing to do something. We know that brief interventions can be useful, and we also know it significantly reduces the likelihood of representation if we take the time to do something about it. So this study was aiming at looking at the eAssist Lite, which is a cut-down electronic version of the full assist in an emergency department setting. We were looking at feasibility of screening people, mapping the characteristics of those who were involved in the study, and also looking at what impact brief advice might have. Participants were everybody who was sitting in the emergency department between May and June on either a Thursday, Friday, Saturday or Sunday evening. We got medical student research assistants to approach potential participants after the triage nurse had advised that they were well enough to be approached, and asked them to participate. We got ethics clearance. Because we were doing a follow-up, we asked them for email or cell phone contact numbers, and they identified themselves for follow-up with a unique code that would only be known to them. We didn't go through hospital records, and we didn't offer any financial inducement. So this was trying to see what would happen in real world. Would people actually show any interest in doing this? For those of you who are not familiar with the Assist Lite, it only assesses last 3 months use. It grades risk based upon answers. We've reduced the items, 4 items for alcohol, 3 for all other drugs, and it stratifies risk. So it's maintained the integrity of the way the full assist operates, but we use factor analysis and item response theory to cut it down to the minimum number of items needed to determine whether there was a problem, but make it clinically relevant so we could then follow through with an appropriate intervention that would be meaningful to the individual who answered the questions. So this was all done by self-administration on an iPad that was locked for purpose. The intervention they received was dependent upon the severity of risk. Moderate risk got brief advice, high risk got a suggestion of follow-up with referral to treatment. We gave them the phone number of the Alcohol Drug Information Service, and they also got some detailed advice, all of which could be emailed to themselves so they could then follow that through afterwards. So what happened? Well, the majority of people were very happy to be approached and be engaged. 3/4 of the people said yes, we were prepared to do it. Everyone who said yes they would actually did complete the questionnaire. Equal proportions of males and females. Majority were in that 20 to 49-year-old age group, which is good for earlier interventions. Majority were in full-time employment, and 1/5 were unemployed. And this was pretty characteristic of the sorts of people that would ordinarily be going through the emergency department. When we look across the rating, and this is all people, all substances, so you can see for every substance it pulls to 479. You can see in the low risk category, the majority of people were in low risk, and alcohol just snuck under the wire, so we can say majority for all, but it's almost 50-50. For those drugs other than alcohol, what that means is that they weren't using at all, but for alcohol, that could mean that they scored +1, so they were consuming alcohol. However, we saw a significant proportion, particularly for alcohol and tobacco, who were positive in the moderate risk range, and similarly for cannabis and lesser for stimulants, and then very small numbers for opioids. And in the high risk range, again, you can see alcohol and tobacco dominating, with other substances less likely to occur. So this is really saying that people use multiple drugs. They don't use single drugs, and that the skew towards low risk, but there's significant numbers of moderate and high risk substance use. So what does that mean when we look at modelling across high risk, which is going across, or down moderate risk? The first thing you can see is that only 180 people of the entire sample had no risk for all substances. So that means that's 40%. That means 60% had some risk. Interestingly, 130 had moderate risk for one substance. Now that has a flow-on effect in terms of time for intervention, because we're only dealing with a single substance and responding to that. That in fact meant that 2/3 of all of those that were just in the moderate risk range was for a single substance. If we look at what the substances were, we can see that predictably alcohol was the most prominent. We kind of expected that, followed by tobacco, but you can see a smattering of other illicit substances being the predominant drug of concern. Looking at that another way, we could say in the total sample, in the moderate risk, we had about 40% had moderate risk, 20% had high risk of the entire sample. If we exclude tobacco, which would be in the background, and we'd expect an emergency doctor, if they came with a respiratory problem, would probably say something about that, it still holds significant numbers. You've got 200 odd people in the moderate risk range, 70 in the high risk range. If we take alcohol and tobacco out, we've got 77 people in moderate, 24 in high. So 40% of the moderate risk group, the principal drug of concern was an illicit drug. 20% of the high risk group, the principal drug of concern was an illicit drug. So these are significant numbers. Contexting this, moderate risk should be receiving brief advice. High risk should be referred to treatment. And we know those things are not happening. So, effectiveness studies of brief interventions, brief advice, there's been several systematic reviews. The majority of them have shown advice is well received, but most studies have been done for alcohol. Non-face-to-face interventions have proved to be effective, and so our tablet-based intervention we would expect to show similar promise, and there's been small RCT studies that have shown promise for drugs. Unfortunately, a lot of the literature is confused in that the intervention is for the wrong group, so we see brief advice being given to people who are highly dependent. We see more structured, prolonged advice given to people who have got simple, low-level problems. And so there's confusion and misunderstanding in the way the literature is represented. The challenges in an emergency department is always going to be times. That's the reason we specifically went about developing a briefer version of the assist, because we're aware of those time pressures, and we're also knowing that there's a limited chance to develop a therapeutic relationship and engagement. So the opportunity to do some self-directed approach is actually a helpful approach. We think screening needs to be quick and easy to do. Several studies have found computer approaches overcame the problem, but confidentiality is key. So in this process, we got people to do it on a tablet where they were just doing it in the waiting room before they went into the service, and they could email the results to themselves and explore the extensive information that was available to them afterwards. When we tried to follow people up, we weren't as successful, so we gave people prompts and reminders to come back to us, and they didn't. Now that could be because we didn't provide a financial inducement, or a variety of reasons. We don't know the reasons, but it's something that we want to look into further downstream. But research is pointing to the potential for doing something on this. We found the majority of people were quite okay with being asked about it. One of the main barriers in the emergency department before it was they won't want to do it. Well, actually, they did. 3/4 of them happily said yes, and there was no barrier that we could align towards age. All people who started finished. The research assistants, interestingly, independently said to us that the methamphetamine users were the most grateful of all the people they spoke to, because they said it was the first time they got any information about risks and harms and strategies to reduce those risks and harms about their methamphetamine use. They hadn't engaged in a treatment setting, and they found it useful. As I said previously, 40% were low risk, 40% were in moderate risk, 20% were in high risk. That, to us, is enough to warrant doing something about it. The College of Emergency Medicine agrees with us, the hospital agrees with us, and other EDs in Victoria have also agreed, and we're looking at the integration of a self-complete platform to enable patient assessment prior to engagement in the treatment setting. Based upon the feedback we got at the time, we made further modifications to that platform. We've now got it available as an app, smartphone app in an Android and iOS form, which will be able to be downloaded from the web, we hope, next week. All the resources that I've talked about can be obtained at the Assist portal. This is funded by our national government as a way of disseminating information about how to do early intervention work. So if you go to that portal, there's online training and a whole bunch of resources, and I'm happy to talk about that later. Let me end by firstly thanking the staff and the patients who were involved in the study, DASA, who provided the funding for the study, and the students who assisted in collecting the data. Thank you.
Thank you, Robert. We have time for a question. Yep. Start there.
Okay, Robert, the people completed this, but it never went to the treating clinicians in ED. This was just an intervention to the person themselves.
Yeah.
And they got email back.
Yeah, so the hospital staff were in two groups. Those who were really excited about this and those who looked at it with dread. So, and when we did the information to staff about what we were going to do, the first round, it didn't look good. There was a lot of unhappiness in the room. By the time we'd finished the study, staff were saying, this is really good and we should be doing more of this. So then they were talking about, so how do we get it onto the patient portal? How can we incorporate this? So the anticipatory anxiety went away. But yeah, we did it as low key as possible because we wanted to get a foot in the door.
Very quickly.
I was just going to quickly ask, is there any way you could tying some health economics stuff around these studies?
Absolutely. If
Yeah.
we'd been resourced to do that, we would have. Yeah.
Is that a plan in the future?
We've been talking with the hospitals in Victoria about that opportunity. There's a PhD student there that wants to do that, so yeah.
Fantastic.
All right. And if you're very brief.
Very quick. Thanks, Robert. I might have missed it, but what was the nature of the feedback that they got?
Okay, so you did miss it because I didn't tell you. So the essence of it is it's a structured process. At the top of it, it gives them their score for all substances. Underneath that, it identifies the risk category for that score and explains what that risk category means. And then there's targeted advice depending upon which risk group they're in, which substance, about ways to reduce that risk, things they can do, and they can email that to themselves. Oh, supplementary question. I don't know if you're allowed to do that.
You got their follow-up data. Have you been able to follow them up?
Oh, so yeah, we didn't get enough people followed up to make sense of what it meant. So, and I'm happy to talk to you about it in the break about what it is. Yeah.
We will take that to coffee with us. Thank you all very much, and could we thank our speakers again?